Audio Jungle. Audio Jungle. Audio Jungle.
Thank you very much for joining us. You're watching yet another edition of the MedFiles program. I am your host, Marianne Waisha. Now, as usual, you know that this is the one medical program that gets questions from you, and we get you a medical professional to answer the questions that we have from you. So in studio today, we have Dr. Monica Nderito, who will be taking the questions that we've got from you for this edition. Dr. Nderito, we say welcome to Three Stones. Thank you for making time. Yeah. So perhaps you could get a brief introduction of Dr. Nderito before we take the questions from our audience.
Dr. Nderito is a medical doctor working at Melchizedek Hospital, currently at the Karen Medical Center, which happens to be a new branch of the main hospital, which is located along Naivasha Road. I've been in the field of medicine for the last 3 years. This is my 3rd year. And I enjoy what I do.
You do?
Yes, I do.
That's good. All right, let's take the first one that we have. Okay, this is a question on asthma, and I guess you would be one to tell us, you know, that there's a lot to be said about asthma. The one question that this gentleman asks is there no cure for asthma? Because he says he has a neighbor who has had asthma for many years, and he has, you know, what he calls the dawa ya kupuliza, which I think, you know, is, I guess we'd assume is the inhaler.
Yeah.
But he's been, you know, on it and sometimes on oral drugs for many years. And he asks, mbona ijapona? Why doesn't this guy get healed? So maybe you can take us through a bit of what asthma is all about, and maybe answer this question on why exactly it is that one can be on medication for so long and it never goes away.
One thing we need to understand is how asthma comes about. Because asthma by itself is a genetic disease. That means it's a disease you inherit in the family line. And a disease inherited in the family line is difficult to cut that, knowing that it's already in the genes. So the best way to deal with asthma is to manage when it's already started presenting. Therefore, what this man needs to do first is to now look at the management of asthma. And in the management of asthma, that's why we come in with so many drugs, so many medication. But before we come into the drugs and the medication, the patient has to be educated enough so that they can know that it's actually asthma that they are suffering from and not just any other chest or lung infections. And one of the things that triggers the asthma, we call it environmental factors. They have a big role to play. We have the physical factors around us, the irritants, the dust, the mites, and also a few of the fumes that are usually produced. Exercise also. We have seen also some bit of emotions. When you're a bit stressed,
when one is stressed,
yes, it can also trigger. It can also trigger these attacks of asthma. And what the patient needs to understand is, if you're already presenting with these attacks, how am I going to deal with them? Because asthma can be controlled to an extent that everybody, yes, to an extent that people may think that you're not asthmatic, because you can keep off attacks of asthma for years without having recurrent attacks.
Yet it's still in you.
Yes, yet it's still in you. So what we need to understand is that, yes, I'm suffering from asthma. It has no cure, but what needs to be done is to manage the asthma.
Yeah.
And one of the major factors that you have to look at when you're managing the asthma is to avoid, what we talk about avoidance. You avoid the causing factor. You realize among the things that I've mentioned about, we have the environmental factors that come into play. So what you do, you avoid what actually triggers that. Somebody will tell you, I went out in the morning, it was very cold and I got an attack.
So
What
then
you
you should
do-
be able to isolate.
Yes, you should be able to isolate the factor so
Yeah.
that you know you need to be warm. Some have even forced people to move out of cold areas into warmer
Oh.
areas just to be able to prevent
Avoid.
the occurrence of those attacks. So when you know the factor that triggers that, that's one of the key factors that will help you to be able to control it.
Yeah.
But you'll have some still having recurrence of these bouts of asthma, and that's why we also need to put in medication in place. And this will depend also on how many, the recurrence of the attacks.
Yeah.
Some may have it almost every other day.
Yeah.
Some
And
will
some
have,
will go for months.
some will go for months. So this is where you grade and you see the attacks. The doctor, or rather your physician that you see, should be able to help you grade the asthma, the extent of the
Depending on the
asthma,
frequency.
and will put you on the medication.
Yeah.
Because we have a variety of medication. There are some that are just short acting that you'll just use for a period of time to control the attack,
Yeah.
and the body responds back normally.
Yeah.
These are the inhalers that you're talking about,
Yeah.
that this gentleman may be using.
Yeah.
Some may not fully control the asthma. So what you need to do is to use, to introduce other, they may still be in form of inhalers, but they contain something we call like the steroids. Because what you're looking at is to reverse that action. Asthma causes narrowing of the
Yeah.
airways.
Yeah, maybe you explain a bit also what goes wrong and then what the inhaler does to correct.
Okay. What happens is that when the body is triggered by the factors that you're talking about here, the airways are the ones that hyperrespond. We call it hyperresponsive airway, such that they cause the muscles within the airways contract, causing the passage of air difficult.
close,
Yes. So that means air may not freely flow in and out. So what you have to do is to reverse that action. And by reverse, I mean to be able to take back
open
the airways into the normal state that they were in. So that's why you have to, the issue of the medication comes in. And that's why at times you will find that you need to combine a couple of medication to be able to reverse that so-called action. Some may reverse on just one medication, some may reverse on a variety of medication. But what we need to do is reverse that action so that the airways now can expand enough for air to flow in and out. And most of the patients, when you meet like the asthmatic ones, they already know this problem very well. They know the drugs that they actually respond to.
Oh.
It's only that now the doctor should be able to help the patient to figure out
What
is
the
that
trigger
whether that
is.
medication is enough for them. Okay, the doctor may also help them to figure out the kind of allergens that cause that, as we're calling it. And then that way we'll be able to fully control that, to control or so-called
Control,
manage
yeah.
asthma per se.
Manage it.
Yes.
So what falls squarely on the patient is to be able to determine or somehow be able to isolate what could be triggering, because you're saying if one says I left the house very early and it was cold and I got an attack, and the last time I got an attack was another time I was rained on, so they're able to
narrow
narrow
down
down and say
something,
maybe it's
to the
cold,
cause.
maybe
Yes.
it's pollen.
Yes.
Yeah.
Yeah.
Okay, so, but basically the bottom line is it is not curable. Once somebody presents with it, there's no way you can take medication and it cures like malaria, or, you know, it clears from the system.
No, because we are dealing with genes here, and genes reside in the body. It's encoded in the body, in the body cells. So saying that you're going to take medication and asthma will completely go, if it's a right diagnosis that it's asthma and just not a lung disease like the bronchitis, the pneumonia, then that means it is difficult, or rather we cannot cure it. And that's why you have to talk to the patient, counsel them, let them understand that yes, you will find that in most of these patients, when you go back to their history, they'll talk about probably their parents, their grandparents, somebody in the family line had an experience of this.
Yeah.
And when you rate it back that way, then you'll be able to help them in the management.
Yeah.
Because some of them may not know, some of them may be in denial. Some of them may say, I don't know anybody in the family who has ever suffered from asthma. But there are other lineages that we didn't meet, that were not there. That means it may have been flowing in the family line that you do not know. And you happen to be the unfortunate one. Yes,
on
to
whom it
exhibit
falls.
the symptoms.
Yeah.
So what we need to counsel these patients is that, yes, there is asthma that cannot be cured. We will not give you this inhaler and say that this will be the end of asthma, but you can
manage, you can
manage
control.
it
Yeah.
by the so-called avoidance and use of medication. And you'll find most patients responding very well, because when they identify what triggers it, they are able to avoid the recurrence of the attacks. Or rather, and also when they have the attacks and they use the medication and they respond well, then they are able to continue with their normal daily lives. Yeah.
And it doesn't interfere with their work. Or
Well-controlled
with their life.
asthma
Shouldn't.
should not interfere with your work.
Yeah.
And that's why you need to see a good physician. Nowadays, we even have chest specialists who will actually do for you all the extensive tests that are required and give you the correct medication that's aiming at controlling the asthma. And you don't even have to miss work at any one day. Yeah.
All right.
Yeah.
Okay. So avoidance.
Avoidance is the key word.
Avoidance is the key.
Yes.
Okay.
And patient education.
And education. Okay.
Yeah.
All right. All right. Let's take the second one. Okay, this has to do with the HIV and AIDS scourge that has been with us for, going to 40 years now. And there's been a lot of education, a lot of progress and development where HIV and AIDS is concerned. One of the main ones being the ARVs. For a long time, there was absolutely no way to control or manage HIV and AIDS. It was just once one was infected, then there was no way of even reversing or prolonging life, anything like that. But now we have ARVs, and another good thing is that in Kenya the government has really stepped in trying to ensure that everyone who needs ARVs has access to them. However, this one viewer asks, is it true what she has heard that some people, after taking ARVs for some time, can develop resistance to whatever chemicals are in it, such that if one has been taking ARVs for some time and they've been, working well for them and they're now healthy, after some time they go back to the poor state that they were in before because of this resistance? Is it true that happens? Maybe start by explaining how the ARVs work, so that we get to now flow into the answer to this question.
Okay, thank you for the question. What happens with HIV once the virus gets into the body? As we know, as per now, we still do not have a cure for HIV, but at least we have something that can reduce the extent or the effects of the HIV virus in the body. And this is where ARVs come in. They are drugs that are designed to act at certain stages of the cycle of the virus replicating or growing in the body, so that it blocks that stage to make sure that the virus does not continue to grow and I would say, form many other copies of its viruses. So ARVs are grouped into a number. They have certain groups depending on the action where they work. Because we have a group like, we call them the non-nucleoside reverse transcriptase inhibitors. These ones will work on an enzyme called the reverse transcriptase, which is an enzyme that is found in the body, that is produced in the body to enhance the growth of the virus in the body. So the ARVs will work, of that type will work by blocking the action of that enzyme. And by blocking the action of that virus, that means that the virus will not continue to multiply.
grow, yeah.
Yes. They work at different sites. We have others like the fusion inhibitors. Fusion inhibitors will work by preventing the virus from getting into the CD4 count cell, such that it does not penetrate through the cell wall into the CD4 cell of the human body, which is usually the main target of the HIV virus. So that is also, that's the place of action for that other class of the ARVs. And others, the protease inhibitors, that will prevent, after the virus has been growing and growing, now it's going to prevent the spread, because some of them tend to separate into many small viruses that now spread into the body and go around the body. So ARVs basically work at certain stages of the virus life, yes, and block it from progressing.
Yeah.
And this way they reduce that's how we say they reduce the level of the viral load in the body because of the action and where they work. And what happens during the intake of ARVs, we can have something called resistance.
Okay.
And
So it is true that resistance happens.
Yes, resistance happens.
Yeah.
And at some point, I can actually say it's not something that you have control, because some people may be very adherent with ARVs, but they still get resistance. And how does resistance come in? When these genes of or rather when the virus that's invading the body starts mutating, they start changing, such that, as I've described for you, these sites, we have different sites of the ARVs action. But now if the virus changes, that means it may take a different cycle from the normal one that we are talking about. And that means it will not be responding to a drug that's supposed to work at that level. And that's why we talk about resistance coming in. You're taking the medication, you may be taking as well, very well prescribed to the body, but now the virus that's in the body has mutated.
It has
changed.
form.
Yes, it has changed. And now the drug can no longer target that site where it was working because of the viral change. Yes.
Okay. So what happens then if you have a patient who presents with resistance to this? What do you do?
I think with the advancement of the treatment, good things are happening, because currently we are able to test drug resistance even in the laboratories. We have advanced laboratories where you can take samples and you're able to analyze which drug is this virus
forming
resistance to. And that means you have to change from what the patient was taking
to another one.
And you incorporate a regimen whereby the resistance is not marked there.
I see.
Yes.
So you have to now get a different drug.
Yes, you have to replace. You have to replace what the virus is resisting, because giving the drug is as good as not giving the drug. Yeah, it's not helping the body. And what you need is to control these patients' immunity and the way they are responding to the drug. So the best option is you find out what the drug is, the patient is resistant to, or rather the virus is resisting, and then you replace it, because as I've told you, we have different drugs acting at different levels. You incorporate another one, and then you form, that is what you call now second line.
Ah, okay.
Yes, that's
where
now the
this
second
line comes in.
The second line sort of management. But you should also, much as you're changing to the second line, you should also look at other factors. Is the patient also adherent to his medication?
In terms of the discipline of taking, if it's
do they take the medication every day? Are they taking the right dose as prescribed by the doctor? Because all these are very important factors to put in place. And you should also be able to find out, does the patient have other disease conditions like probably
TB.
severe diarrhea, such that the patient is not absorbing the medication? Because that means the patient may be taking in orally medication very faithfully,
But it
but
just
the body is
passes
not
through.
absorbing it. So the body will not have enough levels to fight the virus. You should also be able to follow up the patient and find out that, does this patient react to these drugs? Because you will find most patients will get a drug, one of the drugs in the combination gives them certain side effects. And the patient stops taking the medication because they'll say, I take these, I get a lot of nausea, I have a lot of anemia. There are those drugs that are associated with certain side effects. So good follow-up of the patient also is important to be able to rule out the issue of, that's where toxicity comes in. Is the patient reacting to a drug that is discouraging him from taking the medication? That means you are missing out something in the management. And we replace that drug with another one. But if the patient now starts developing resistance, you've done resistant test, you have replaced the drug, patient, there's still that also other probability of patient developing resistance also to the second line. And now what you have to do is to keep filling in these gaps. Although you will find in such cases the end term result is not very good. Because if you take most of the drugs and you're resisting them, that means it's like you're not taking your medication. And you find the patient will have very high viral load, very low CD4 count, and will deteriorate.
So how many lines are there now? How many lines do we have? We say we've moved from first line to second line, then
basically we have first line and you have second line. But now it's up to the physicians responsibility, or rather to follow up the patient, okay, and follow up after the patient changed from the first line to the second line. How is the response? Most of the patients will respond, but you have exceptionals who will still develop after some time resistance even to second line. So now that's where the physician comes in and tries to
find out where the holes are.
Yes.
Okay, you mentioned the discipline that a patient is, a patient has. So there is a direct relation to, say, a patient who doesn't take their medication regularly or as they're supposed to. If it's, say, 3 times a day, they skip a dose here and there. There's a relation between that and them developing resistance.
Yes. And the reason why they're going to develop resistance is because they will not have enough drug capacity in the body, if I can use very simple language. Their drug levels in the body to be able to fight that virus are minimal. That actually gives even the virus more chance to mutate.
And work against the drug.
Exactly. That's why adherence and compliance to medication is very
because it doesn't important. Then leave room for the virus to mutate.
You treat the virus aggressively and you get good results.
Okay. All right. Let's take the last one for today. Okay, this is a young lady who talks about ulcers. And I think what struck me was that the age of patients that we used to hear of having ulcers way back was not as young as we are seeing them now. This is a fairly young lady who says she has had ulcers for so many years and has been on loads of medication, has tried just about every drug there is out there. And she says she even tried the herbal medicines, the mitishambas, and that hasn't worked either. So she's, lost on what next, what to do. I don't know what your take on this is.
One thing she needs to understand is that, or rather we all need to understand, is that stress per se is just associated with ulcers. Is associated,
But it's
but
not quite.
it is not the main cause of
It's,
ulcers. So there are many other factors that cause ulcers. So would this lady be suffering from one of the many causes that we know of that would be causing
because she
ulcers?
actually says she was told that ulcers have to do with stress, but she says there are times when she has absolutely nothing bothering her. She's fine, she's happy, she's comfortable physically, psychologically, emotionally, but the ulcers still act up.
Yes.
Yeah.
That's why, and that's why I'm talking about knowing the factors that would actually cause the ulcers, so that we just don't restrict ourselves so much into talking about stress and we forget that there are many other factors out there. For example, we have a bacteria, the so-called H. pylori bacteria. It's a bacteria, mostly resides in the stomach mucosa, buries itself there, causes a lot of inflammation and a lot of swelling there. And with time, ulcerations start developing.
On the stomach.
Yes, on the stomach. Currently, it's actually one of the major causes of the ulcers that we talk about. And if you have this bacteria, the mainstay remains. It's a bacteria. It needs to get eliminated from the body. Because as long as it persists, that means the problem will persist. And she will keep complaining about ulcers. She's not stressed, she has taken milk, she has taken, some will go to the extent of taking
toothpaste.
Yes, toothpaste and salt, but it's because the causative factor is
Has
still
not
there.
been dealt with.
And what we need to deal with is the primary cause. Treat the primary cause and you have treated the disease. So like the bacteria in question, the H. pylori needs a combination of antibiotics and a protein pump inhibitor, which regulates the gastric acid production. It actually is, the treatment is a combination of 3 drugs, 2 antibiotics and 1 PPI, protein pump inhibitor, that helps to regulate the gastric acid production. Because also excessive gastric acid production is what now will be triggering the pain, because we're talking about acid being produced here over an ulcer. So it causes a lot of pain. But with the regulation of the gastric acid that's being produced,
And then the antibiotics.
Yes, and the antibiotics now will be to kill this bacteria.
To kill this bacteria.
Yes, so that is just one of the factors. Talk about other factors, like some drugs that we are so fond of taking, the NSAIDs, non-steroidal anti-inflammatory drugs. They also, the classes of the, most people will take them for pain unknowingly.
Just painkillers.
Yes, they're actually mostly painkillers and take them a lot. The so-called the class of the diclofenac.
Which
and no, diclofenac per se, I'm sure most of us know the diclofenac. It's an NSAID. We talk about even Panadol per se. Talk about Brufen. All these are drugs that
standard painkillers.
Yes,
that
you will
we
find
use.
somebody, you have a small headache, toothache. Everybody runs to go and pick them up for pain and say they have no side effects. They have actually showed a very major role to play in the causation of ulcers. So that is something that should also have come in, something that should have come up from this lady. Does she have that long history use of these drugs?
So it would be a problem if somebody was using this random painkillers over a long period, frequently for a long time.
Yes, can also cause the ulcers to come up. We also have other factors like smoking. Smoking is also very highly associated with causing ulcers. And we have other minor factors that like diet, like the acidic foods, the fruits, oranges, some will take.
But those ordinarily shouldn't cause ulcers if it's
what they do,
a lemon or an orange.
What they do is because, remember, they contain acid. So, and here we are talking about hyperproduction of also the gastric acid juice. And here we are adding more acid into the body. But it is not a major factor. We call them, they are small minor factors that
maybe would just aggravate.
That will aggravate the ulcer that has
another major cause.
Yes,
I
that has
see.
already formed. Yeah.
All right. So it's not always about stress. I think
It's
that's
not
the main
always
thing I've
about
picked up.
stress, yes. There are those other factors that you really need to have checked. Although you may look back at all these things and you find that they are negative. The next important step that you want to take after finding out is you want to have like a check of, let's say, the stomach and see what actually is happening. And that's where the issue of endoscopy comes in, whereby you have the doctor do an endoscopy examination on you, and this helps to visualize the ulcers, the location, their size.
Define endoscopy.
Endoscopy, I would call it, it's a procedure. It's called, what you do is that we have like a computer put in place, and you have something like, I would say, a guide wire with a camera. And then you just sedate the patient a bit, insert it into the patient's mouth, through the esophagus, and it goes down to visualize all the area, down the esophagus, into the stomach, into the duodenum. And it's able to pick out whatever.
So you're able to just look.
Yes, you see like a picture on the screen. If it's an ulcer, you're able to see it, you're able to define how does it look like. Is it a big one? Is it a small one? And the good thing about endoscopy is that you're able even to take a biopsy. You go and you find it's like there's an ulcer there, you just
take a chunk of flesh.
A chunk of it, and you go work on it to be able to define. Because we know there's also chance of ulcers developing into cancers, especially like we saw the so-called gastric ulcers. These ones are the ones that are located in the stomach wall. They have a very high chance of turning into malignancy, we say. So you take a piece, you go do a biopsy to be able to verify, is it does it have signs of getting malignant or rather cancerous, or is it just a normal ulcer? And then of course you're able to intervene after that. Yes.
Okay.
Yeah.
All right, that's interesting. I didn't know that's how an endoscopy works.
Yeah, that's how it
That's how it works.
Yeah.